All right, so this is the client with the knee issue. You can see that his left knee, that's his normal knee, and that's the shape of it. And let's get a shot from the side kind of over here so that you can see that pretty much lays pretty flat on the table, more or less. It's close, it's awfully close. And then here's the knee that was injured. Football twice in college, operated on twice? Once. So they operated on it once. You could see the connective tissue is just a completely different arrangement. Completely different arrangement. And if you come down to the side, that one doesn't come close to laying on the table. So extension is compromised, and certainly the shape of the joint is compromised. Some of the body work that would be involved would be to push in on the joint clefts, both sides, while you put movement in it. 2-on-1 would work great, but working 1-on-1, some of the pieces would be get in a position where I feel for, there's the joint cleft, so I'm going to put pressure in there while I put movement in. Pull on it a little bit of traction. The pressure focuses movement into the joint, and then movement, of course, is going to attract collagenase, and with time we'll get this. And we're also going to do some corrective exercises with this guy. With this guy meaning this knee, and this guy. Same side, same thing with this side. I'm going to find the joint cleft, put pressure in it, put movement in, a little bit of traction. So I can, as I'm doing, I can get my leg on the table, make this easier on myself, and work in there. That's one of the main techniques. Face down can do the same thing, and with movement, I can also get my arm, my hand, kind of anything in the crook of the knee, use enough pressure to give a little bit of traction. Use that traction to get movement in there. And I want to focus a lot on flexion extension and feed in very little side-to-side movement. Because what we're really doing here is doing our best to make a fresh knee joint. It's been compromised for years, and it's certainly still a joint because it still moves. But comparing it to this joint, it's got a lot of problems. This is never going to be like that. Our goal would be to get it as close to that as we can. So the body work would be, to repeat, one of the most effective techniques I've found with things like this so far is pressure, feeding pressure into the joint cleft while I move it. I think you could maybe tell from, yeah, okay, there's the joint cleft on this knee. You kind of see where it is in relation to the whole knee joint. Now I come into this one, it's in a different place. It's a little higher. So compared to this knee, the joint is actually a little lower. Because after surgery, after this thing came out, it was in a cast for a while. About how long?
2 months.
2 months in a cast, and without any movement, the connective tissue just starts to become a mass instead of differentiated into a joint. So when it started moving again, enough had settled in that the joint actually, where it moved the easiest, moved down. They're not doing this surgery, of course, anymore. This was 40 years ago. 40 years ago, surgery was a lot more primitive than it certainly is now. And they would have this knee moving a lot sooner now than they did back then. It wouldn't be immobile for 2 months unless it was like seriously messed up, like in a car accident or something, but not in a sports injury. So, so yeah, the joint's different. We're never going to get this one to function like this one. Therapeutic goal, to get it as close as possible, get them as functional as possible. All right, let's go ahead and get up. Let's show the film. show the phone, the piece that you're doing in the Parker Lounger. So Parker Loungers are excellent for this. So the idea would be for them to get in this nice comfy Parker Lounger and to put the the bottom cushion and where he's sitting in it to get what feels like to him to be the most traction on the knee, the most that it can open. And that's a real nice position for that, right? And then straight flexion extension. Yeah, just flex and extension. And then you can also push into the, push straight into the bolster too, or into the, whatever you call this thing. Yeah, yep, push into it. And you're not looking to, he's not looking to use a bunch of strength, he's just looking for movement. Movement, and especially, like an exaggeration of this would be to just go back and forth without really raising your leg off of this thing. So just push into it a little bit, and then lift off of it just a bit, right there. Yeah, just that, and back and forth. So that right there we're going to have the most traction. You probably feel the most traction in there. More traction that's in there, the better. Without it being so much traction that his reflexes are going to protect it. So you could certainly put too much traction on. He's going to fire muscles to stabilize the knee. We're going backwards. He could do this with a little bit of weight. I would probably say a pound, 2 pounds of weight, something like that, just to give a nice, easy traction. Traction will create a little more space. The more space that's created with movement, the easier it's going to be for collagenase to go in there and do its thing at dissolving collagen fibers. And we'll create a more functional joint. That's kind of that's the gist of it. That's the gist of it. Taking your understanding of connective tissue, that dynamic of pressure results in more collagen fibers, movement, more synovial fluid, movement attracts collagenase. So we can either build up connective tissue structures or free up and open up connective tissue structures. And that's what we're looking to do here, free up and open up connective tissue structures. A little bit of traction, more collagenase, more of a joint. So we're looking to make as much of a knee joint here as we can. That'll get it closer to function like the other one. Cool. I think that's all I got to say right now.